Welcome to Raaonline. Today we will be talking about management of peripheral vertigo. So when we talk about vertigo, we have to know about a couple of terms. Giddiness. So when a patient comes to us, they come to us saying that they are feeling giddy, and giddiness is a sense of feeling giddy, and what we assess the patient is for vertigo. Vertigo can be defined as a sensation of motion either of oneself or of the environment around you. So either the environment moves around you, a reeling sensation, or the patient feels that the patient is moving around. So if you are using a pogo stick, you are not having vertigo. So when we talk about vertigo, we have to realize that vertigo is not a disease entity, but it is a result of physiological or pathological factors. It is a multisensory and a sensory motor syndrome which perceptual, postural, oculomotor and autonomic manifestations which is induced by unusual and unadapted stimulation of normal vestibular system or a pathological dysfunction. So we have to realize that balance is maintained not only by the ear but also by touch, body positioning, posture, which all play a part, and the integration of all that is what we see as balance. And if there is imbalance in any one of the system, you get giddiness. So we can say that vertigo is caused by the mismatch of these different systems because of faulty inputs. So there may be a mismatch in static and dynamic cues for posture which is provided by the vestibular system, or it could be the somatosensory input. So we have the eyes which send in signals to the cerebellum. From the ears through the semicircular canals, you have the inputs which come in, and through proprioception, you have the touch and position sensation from the limbs and the muscles, which are the efferent organs to help body maintain its posture. Now we have to remember that balance is maintained by the redundancy of these systems, and we have a lot of compensatory mechanisms in place where when one position becomes faulty, the other one takes over and compensates for the faulty system. So the treatment of any vestibular dysfunction usually depends on this compensation mechanism. So vertigo can be either physiological, where there is an intact vestibular system but there is an overload of stimulus. Example, in motion sickness or in height vertigo, or it could be pathological because of dysfunction of one or more of the afferent pathways or the sensory system. So the main stimulus or reflex we use to gauge vertigo is the vestibular ocular reflex. So the VOR, the vestibular ocular reflex arc, is used to stabilize gaze during head movement with eye movement due to activation of vestibular system. Okay, so what happens is when the head turns, the eye helps maintain position and also gives us to the vestibular pathway to maintain balance. It is primarily responsible for posture maintenance, and most of the tests we do to assess vestibular function is the analysis of the vestibular ocular reflex. So for example here, so when the head is turning to the left, there is a compensation of eye movement to the right side, and the blue one is the inhibitory reflex and the red one is the excitatory reflex. So when the head moves to one side, you have the medial rectus on one side giving excitatory signals and the lateral rectus on the opposite side giving inhibitory signals, and together these compensate each other, and these two signals together help maintain a posture. If there is going to be a defect in either one of these pathways, then the patient will feel unsteady and giddiness ensures. So how do we examine a patient with vertigo? The most important part of patient examination in a person with vertigo is the history taking. So that is why normally when a person comes with vertigo, we generally have to spend a lot of time with the patient, of which 60% to 70% of our time goes in history taking. It has to be detailed. We have to talk about the onset of the vertigo, the duration of the vertigo, whether there is any frequency or episodicity, whether there are any triggers which are present, and whether there are any predisposing factors like diabetes or hypertension or any injuries, all these things, and whether the associated symptoms affect the ear or it is neurological, cardiovascular or gastric. So when you look at a clinical neurootologic examination, the primary exam, so we cannot miss any of the ENT examination and it has to be detailed. So unlike other ENT examination, when a person comes with vertigo, the examination has to be steady and detailed without missing any of the steps. So we do a thorough otologic examination, including an otoscopy, do a tuning fork test and use a Valsalva test to check for any eustachian tube dysfunction, and it also will help us find out whether there is any fistula sign and also whether there is any giddiness with high frequency sound. Then you do a thorough cranial nerve examination, testing the cranial nerves 1 to 12, and you test for oculomotor function with looking for nystagmus, see whether convergence is normal, whether there are any smooth pursuit or saccades. And we can assess the vestibulo-ocular reflex with the help of a head thrust test, a head shake test, and look for doll's eye movement. And we test for gaze and gait and balance by doing a Romberg test. And if Romberg test is negative and you still feel that there is a possibility of vestibulopathy or unsteadiness, then you can do a forced Romberg test, then test for gait and do the Unterberger's test. Then it is not complete without the cerebellar function test, and if we suspect a positional vertigo, we have to do a Dix-Hallpike test. And we can also do the caloric test to complete the neurootological examination. So what are the abnormal signs that we find? So when we look at when you do an otoscopy, normal sign is that of an intact TM. Abnormal signs, you may have a perforation present, there may be a retraction pocket or a cholesteatoma, or there may be some pulsations in the middle ear. Nystagmus, normal sign is no nystagmus, and in case of peripheral nystagmus, it might be horizontal and the nystagmus might be fatigable. If it is vertical and persistent, it could be there is a central problem present. In case of smooth pursuit is accurate when things are normal, and in case of central problems, that is broken. Similarly, saccades are absent in normal individuals, but in case of a central problem, they are present. And in case of head thrust test, you have a catch-up saccades which are peripheral. In case of peripheral vertigo, and head shake test, we have a brief horizontal nystagmus in case of a peripheral vertigo and a vertical nystagmus in case of a central vertigo. In case of Rombergs or forced Rombergs, as I said, you have a positive sign in case of a vestibular deficit, a peripheral vestibular lesion or a posterior column lesion. Gait, in case of cerebellar dysfunctions, you have a wide base gait, and in case of Parkinson's disease, you have shuffling gait. And when you ask the patient to do a tandem gait, in case of cerebellar or bilateral hyperfunction, vestibular hyperfunction, they will not be able to do a tandem gait. And in case of an uncompensated vestibular deficit, the patient sways to the uncompensated side. And in case of Unterberger test, a deviation 30 degrees or more to the affected side is seen. And in case of Dix-Hallpike test, usually positive in benign positional vertigo, and you will have a persistent vertical nystagmus in case of a central vertigo.